everybody. Good evening. Thank you for joining us. Today's lecture will be given by Dr. Bruce Zhang, one of our new physical medicine and rehabilitation physicians here at Rothman Orthopaedics. Dr. Zhang sees patients at our Chalfont and Willow Grove offices, and I know he'll tell you a little bit about himself. If you have any questions during the presentation, please feel free to enter them at the Q&A box at the bottom of your screen. We'll take a few minutes at the end to answer as many as possible. And if you have any questions, you can also ask in the chat box. Dr. Zhang, you can take it from here.
Thanks, Natalie. Appreciate it. Hi, my name is Bruce Zhang. I am an interventional spine physician, which means I offer minimally invasive procedures such as injections and other, let's say, percutaneous offerings to help manage pain related to the spine. I should probably give a little background info. I'm from the area. I went to Cheltenham High School. Went to med school at Temple, and so I'm, very much a local boy. But I did end up spending a couple of years practicing outside of the area. So for a few years, I was up in Scranton, bouncing between offices in Scranton and Bethlehem. And I guess I missed home, so now I'm back home. Today's lecture is on well, it's on interventional procedures, but by no means is it supposed to be a comprehensive lecture on the entire array of things that we offer here at Rothman. It's just not realistic to talk about all of that. That's probably like a multi-session 4-hour lecture series, and that's just, I think, unproductive for our purposes tonight. Instead, I thought about what might be, a best use of our time, and I realized that, the reality is most of the time when I see patients, if I see 25 a day, I would say 20 of the patients, I'm having some version of today's PowerPoint, right? The conversations in the office is basically some sort of iteration of that. And so I wanted to go over essentially what the disease process is for most common forms of back pain and related conditions, and then the procedures that are designed to help with that. So I'm hoping to form a storybook that sort of makes sense to everybody, hopefully to me as well, right? And then kind of explain then what the procedure would be and how it would be helpful in that context. And so in this case, we're going to be talking about some of the most common procedures that I offer for the most common complaints that I see in the office day to day. Okay. So, uh, I can't seem to get on to my next slide. Here we go. So why this topic? Well, 80% of the adult population will experience some form of back pain in their lives, the kind of back pain that makes them want to go see a doctor. So it's debilitating. Related to that, a lifetime risk. So so at any given point in time in your life, you have a 10% chance of developing something related to back pain. That's lumbar radiculopathy, which is the fancy term for a pinched nerve in your spine. And colloquially, people often refer to this as sciatica. I would say that the more specific term is lumbar radiculopathy, and that's back pain with shooting pain going down the legs. And above the age of 60, about half of people will develop clinically significant, and I mean that means symptoms, not just pictures, but having symptoms of spinal stenosis. So this back pain related issue from the degenerative conditions that cause them is extremely, extremely common. Just about every single person in their life, if they live long enough, will go through some iteration or version of this. So this is my slide basically explaining that I wanted to talk about the sort of the process of this of back pain and why the injections I offer might be helpful. So again, not the comprehensive story, but rather the most common things that I offer for the most common conditions that I treat. So anyway, any sort of form of explanation of an intervention probably should go back in time a little bit, and we should probably start from the beginning and talk about the anatomy behind all of this, and the disease process. And I'm hoping that it's going to be something that's easily digestible. So we'll start with some anatomy, and so I don't want you to get bogged down by detail. When we talk about back pain, we are assuming that the back pain is related to your spine. Okay. Now, in real life, that's not always the case. There's other stuff that can happen, but by and large, we're talking about spine-related back pain. And you have a cervical spine, a thoracic spine, and a lumbar spine. For purposes of convenience, we're going to focus on the lumbar spine today, but everything I talk about today will apply to the other parts of your spine as well. And the key here in this slide is to appreciate that your spine is not just a single entity. It's actually multiple segments, right, that comprise the full. So breaking down the spine, it's made up of different segments. Okay. I don't know if you can see my mouse, but if you appreciate that the spine, the big building blocks here is that this is the vertebral body. Okay. And that's the bone, right? And we call it the vertebral body. The vertebral body um, talks to the next vertebral body via this little connection here. Okay, so each vertebral body talks to the next vertebral body via this connection, and we call that the facet joint, or it is a joint. So that's one connection point. And in between each vertebral body, you have a disc. Okay, and of course, because it's in between the bones or in between the vertebral bodies, it's called the intervertebral disc. So again, vertebral bodies making up the building blocks, your Legos, right? And in between is the intervertebral disc, right? And then of course the connection point between each of these bones, there is a joint there. The medical term is the facet joint or the zygapophyseal joint, but for your purposes, just appreciate that this is the spine joint, okay? So the next item to introduce here is that in between each one of these bones, and maybe I'll go back to the last slide because it was a little cleaner, but in between all of these things, right, there's these little spaces or these little windows in between each bone, right? And this window is called the neuroforamen, all right? Uh, Neuro means nerve, foramen means window. So this is the window where the spinal nerves exit the spine. Okay, so here in this drawing, you have the bones again, vertebral body, intervertebral disc, joint, and in between all of those structures, there's that nerve that comes out, the intervertebral window or the neuroforamen. So these nerves in this section of the spine, these are nerves that all travel down, eventually lump together into your pelvis, and then the individual nerve branches will then go down into different parts of your leg. So each one of these nerves supplies a different part of your leg. You've got one nerve that supplies the front of your groin or crotch area. You've got another one that goes down in front of your thigh. You've got another one that goes down the inside thigh. You've got another one that goes down the front of your thigh and then the inside of your shin. You've got another one that goes down the back of your butt cheek, the side of your thigh, and then the side of your calf, and so on and so forth. And so the important thing is that the spinal nerves that you just saw there both provide sensation into different parts of your legs and also provide function, meaning motor function. So sometimes there's weakness associated, right? And weakness has specific patterns, and that depends on which nerve might be involved. So this depiction here is only showing you the diagram of sensation, but what happens is with all these nerves that get compromised, we've been able to map out and draw out which part of the leg the nerves sort of correlate to. And this picture sort of depicts that for you guys. Let's talk about the disc that's in between the bones. This is the intervertebral disc. Okay. So, uh, again, not to get too deep into semantics, the disc here, this is a top-down view, and there's an outer layer called the annulus fibrosus, and an inner layer called the nucleus pulposus. And who cares about that, right? What this really means is that this disc, especially a young, healthy disc, is essentially a water balloon. Okay, so the picture on the right is showing you essentially what that means, a water balloon. And so in between each bone is a water balloon, and the water balloon serves to carry the weight and provide what's basically nature's finest suspension system for you. It's a reason why when you were, let's say between 15 and 20 years old, you can do really dumb things, which we all have in our youth, and nothing happens to your spine. It's because you have all these water balloons. And just like any water balloon, if you experience force, because there's water inside of it, the water will then push out in an even distribution against all of the outer walls of the balloon. And that's what this picture here is depicting. right? And so the top-down view again suggests that if you push down the middle of the disc or water balloon, well, then the force gets distributed throughout the entire spine. Okay. I believe the term for that is hydrostatic pressure. Okay. For those of you that took physics in high school. So, what's important about this disc is that your position or how you bend at the torso uh, has tremendous implication on how much pressure is actually being felt by the disc. So, so this picture, uh, basically a poor medical student, several decades ago, someone stuck a pressure meter inside one of the bottom discs in their spine, and the bottom disc is the L45 or L5S1 disc. In this case, the pressure meter was inserted into the student's L45 disc. And the measurements here are in pascals, which don't worry about it's basically a measure of pounds over a square area. So again, we're measuring pressure. And the idea here is to get an idea of how your pressure in that disc increases or changes depending on what position you're in. And so if you notice at the L45 disc, which is at the bottom of your spine, if you sit down, your pressure is at, this is again, it doesn't matter what the number is, but your pressure is at 623 kilopascals. But when you stand, the pressure actually goes down. Okay. And likewise, when you lay down, in this case, when gravity is now perpendicular to the water balloon, right? Instead of pushing down on the spine, you're now, instead of pushing down on the spine, you're now perpendicular to that force. Oh, and actually, there's very little pressure at all. And I do want you to pay attention to the fact that when the gentleman bends forward while standing at the waist, or so bending forward, the pressure goes up exponentially. It's a huge amount of pressure. And then for reference, right, comparing the pressure here in the disc, well, the tire pressure, a fully filled tire pressure is at 300 kilopascals. And so at baseline, just from sitting, the disc pressure here is double that of a car tire. And you can kick a car tire, you can barely make a dent in that when it's fully filled, right? That's usually most tires are between 30 to 33 psi. You kick that, it's a hard rock. Well, imagine double that pressure inside the discs inside your spine. And that's the point of this slide. So, with all of that being said, I think I've now got the building blocks for me to talk to you about what's called the degenerative cascade. Okay, so we're going to go in order, and so we're going to start from the top and move down the screen. Okay, so the only two variables in the degenerative cascade in this particular model we're going to use um, is gravity, which is the force pushing down on the disc and the spine, right? And time. Okay, so the story doesn't care if it's a bunch of gravity in a small amount of time or a small amount of gravity in a long period of time. The only two variables that matter is gravity and time. Okay, so so let's start in the very top. So in the very beginning, the person's healthy. There's no issues. There's no disc problem. There's no spine problem. There's no joint problem. There's nothing. It's just force pushing down. Okay. So in the first model, sometimes there's so much pressure in a short period of time, or maybe there's just enough pressure in a longer period of time that you twist and turn and the water balloon pops. And so, if you ever played around with water balloons, and sometimes you squeeze and squeeze and you think nothing's wrong, and then for whatever reason, it just pops, right? And so in this scenario, it's an abrupt amount of force. And it just so happens that, well, if you have more force in the middle here, it's a lot easier to push this material off to the sides, right? Again, so think about this, right? If you push on one side of a water balloon, where does the balloon pop? It pops in the other direction, right? So in this case, if you push down in the middle, you can pop in the front, you can pop in the back, but it just so happens for whatever reason, the wall of the water balloon is a little weaker on the backside in all of us. So things tend to pop more towards the back. Okay, so in this model here, you have disc herniation, meaning the water balloon has popped or your jelly donut has popped, and now the jelly contents has moved backwards, right? Well, that popping can cause severe back pain. Typically, that back pain is in the middle of your back, and it can radiate into the butt cheeks by itself, okay? And usually the classic pain is worse when you bend forward and when you sit, because as we know from that previous slide, when you sit or when you bend forward, you put a lot more pressure on that disc, right? And so it pops more material backwards. And usually this happens in a younger person. So usually between the ages of 20 to 40, that's the classic population. But there are exceptions, right? Now, if the pain, now remember in our previous model, what's in this window here, right? There's a nerve. So if the disc herniation is big enough, not only do you have disc-related pain, that disc can also push against the nerve, which would then cause that shooting pain uh, down the leg in the distribution of that nerve. Okay, so that's your explanation for what we call discogenic back pain, and also your explanation for lumbar radiculopathy or pinched nerve in your spine, or colloquially people will call it sciatica, right? Okay. Stage number two is let's say disc herniation happens or doesn't happen, right? Eventually, your body will eat away at that jelly donut. But nevertheless, that water content is now gone and it never grows back. And so either that scenario happens or there's a slow and steady process of gravity pushing down even more over time. And now nothing really happens to the disc per se, except that the the bones that are being propped apart by the disc are now coming closer, right? They're sagging together. And so that's why people above the age of 40, 50, they start to notice, hey, I'm not as tall as I used to be, right? Well, do you remember previously that the bones actually talk to each other back here? So these joints are actually reliant on this disc uh, maintaining the relationship, right? And if you notice, these joints are actually in a slanted formation. They're kind of like roofs on a shingle. And so these joints are actually responsible for when you stand up straight and when you bend backwards, that's what the joint does. It allows you that motion. Well, now imagine the disc is dried out from gravity and now the bones are grinding together. Now the joints are grinding together so that each time you stand, there's a lot more force between the joints. Well, if you multiply that over multiple sessions of standing and grinding, and you multiply that by many years, eventually that cartilage wears out. When a cartilage wears out, now when the bone grinds, it is literally grinding on bone. And so that in and of itself can cause back pain. And that's back pain that typically gets worse when you stand or when you bend backwards. And this is typically pain that it happens in an older person, right? That let's say at least 50 years of age. And classically, it's, I stand and stand, and now when I stand for too long, when I'm doing the dishes, my back hurts. And it's usually at the lower back because the discs that get flatter are usually the ones at the bottom of your spine because they're the ones that carry the most gravity. And over time, what ends up happening is that your body will put more bone down because it can't replace the cartilage, so it just puts more bone down. So that's why the joints not only are they stiff and they're bone on bone when they grind, they also are bigger. And so the analogy here is if you look at your knuckles, right? For those that are above the age of 60, not to be offensive, of course, you notice that your knuckles today are a lot bigger than they used to be, 20, 30 years ago. It's the same process. And the same thing happens in your spine. Okay. So as a consequence of this pathology, eventually the discs will completely flatten out, right? They completely flatten out. And one consequence of that is, well, there's no more disc material to herniate anymore. So most likely you won't herniate any discs, okay, at this point, at this later stage. But now the vertebral body and the vertebral body are basically almost bone on bone. And so you can have the vertebral body based pain as well, which is back pain, right? Just predominantly back pain. And as a result of this loss of height, well, all of the structures that are maintaining the stability of your spine are now compromised because you don't have any tautness in the spine, right? Imagine you have rope keeping the spine aligned here. Well, that taut rope that's keeping things aligned requires that the height of this item is the same height or same length. And if you suddenly lose height on something that you're keeping stable with a piece of rope, well, eventually that bone can slip. And so at the very bottom of your slide, this is called spondylolisthesis, which is a fancy term for this bone is now no longer 100% aligned on top of the bone beneath it. Okay. And as a consequence of that, now the facet joints that were already roof on roof grinding together. Now, not only do you have a downward force caving the joint in, you also have a downward and frontward force slamming the joints together even more. So that can be quite painful in the back. And of course, the one thing I want to point out is that what are we forgetting about? We're forgetting about the window where all these nerves are coming out, right? And so each one of these scenarios, especially towards the end, that window, that nerve window, the neural foramen where that spinal nerve comes out, it it's almost like three-dimensionally that window is getting compromised and it gets more narrow. Okay. So each one of these conditions can cause a pinched nerve in your back, which causes either back pain or a shooting pain down the legs. Which brings me to my final scenario, which is called spinal canal stenosis. Um, in our world, we sometimes call it central canal stenosis. So in this scenario, if you have a disc bulge that's, losing height, but also increasing in diameter because it's getting flattened like a pancake and therefore pushing backwards. If you have um, joints that are getting more arthritic and getting more big, right? And as a result of all that, your bones are now shifting forwards. Well, what's the consequence of all that? Well, what's caught in the middle? Your spinal nerves. And so spinal stenosis, this is the reason why that early fact about 45 to 50% of people above the age of 60 will have spinal stenosis. This is why. Because after 6 decades of life, most people will experience some form of this degeneration and joint arthritis and instability in the spine that leads to that scenario. And for those that don't know, the classic scenario of spinal stenosis is the person that stands up, but can't stand for a long period of time, tries to walk, but then after a couple of steps, since usually, a stereotypical number of steps, it's always after 15 steps, my legs they start to burn and they get heavy and they feel tired and I have to sit down. Or after 15 steps, I have to lean forward and I have to lean on my walker or I have to lean on my shopping cart to go grocery shopping. And that's the scenario. And it's because when you stand up straight and bend backwards, you're narrowing that canal. So you lean forward to open things up. So that's like the end stage, so to speak, of this entire phenomenon. Okay. So that's the first part of my slide to explain to you basically the storybook fashion of how this begins. And if you notice, this is one continuous story. We can call things different diagnoses, but what we're really doing is we're looking at a different chapter in the same book, right? So this process, as soon as you come of age and you begin standing upright, once you finish, growing up and finishing puberty, basically, this process happens to every single one of us, and it's a matter of what stage you're in that story. Okay. So we'll talk about treatments. Um, so the mainstay of conservative of all treatments, right? Of course, the first is understanding the disease and getting a correct diagnosis. And I'm hoping that after those couple of slides up front, there is a better appreciation of what the process is. And but you start with the right diagnosis. The next step is always going to be some form of physical therapy or chiropractic manipulation. And I'll explain why. Okay. Of course, plus or minus medications to help treat pain, right? And then finally, the procedures that I'm going to focus on today. And finally, surgery afterwards. And appreciate that this is basically a reverse pyramid, right? So almost everybody's going to go through uh, physical therapy, and most people will go through that. And for a lot of people, that's enough to treat their problem. Some people will need medications, or I should say, a lot of people will try medications. And then the step above that, some people will need injections, but not most. And then, of course, the final step is very rarely, actually, do people really need surgery to treat this pain, but there are a select few that need it. So it's a reverse pyramid, basically. Okay. So focusing on the physical therapy, well, I just spent the entire last, I don't know, 25 minutes talking about only two variables, right? It's gravity and time. And unfortunately, there's no magic way to reverse time. If I could do that, I don't think I'd work at all. And I also realistically can't get rid of gravity. And so most of us are not going to be like Elon Musk and just randomly fly or develop a rocket program to fly to the moon where there's no gravity. Most of us don't live underwater, and most of us don't live upside down. So it's really hard, right? So the only way, from a realistic standpoint, is to find some way to have your muscles, which you have a couple, especially these ones here. These are the multifidus muscles. These are the muscles that are right next to your spine. It's that deep layer that you can't even feel when you touch your back. It's actually deeper than that, and it's right next to all these vertebral bodies. And so, if you can get those muscles to activate and be strong, in conjunction with all of your abdominal muscles, right? The core muscles there, it's three-dimensional, right? Three-dimensionally, if you can get those muscles stronger, they will help collectively push upwards, right? And also provide stability when you bend. And so, what's your analogy? The analogy here is the Eiffel Tower in Paris is not just a straight stick, right? If you come further down, you'll see that there are phalanges on the side. Well, this is the same concept, right? If your muscles are stronger, especially at the very bottom, your core, this helps you prevent worsening of the worsening effects of gravity on your spine. So everybody's going to go through some version of physical therapy, and that's so I want to spend some time on this slide. I think it's really important. I'm a huge believer, and I prescribe it. For anyone here that's already one of my patients, you'll know I prescribe it almost all the time. Right? Okay, so interventional procedures, which is again, I guess, the focus on in this talk, they're indicated if the PT uh, doesn't work, which sometimes happens, right? You can imagine scenarios where you do all the exercises in the world and you have the strongest abs in the world, but you still have a disc herniation, or maybe you're a 65 plus year old and there's only so much core strengthening you can do safely, right? So injections warranted then after you've given that a try. Or if the pain is so bad, and you'll usually know who it is, and usually it's pretty obvious that going to physical therapy literally makes the pain worse, or they literally you can't even get out of bed. It's so bad, right? So the first thing to introduce is an epidural injection. The indication for an epidural injection is either a disc-related pain issue and or the disc is irritating the spinal nerve. So you have pain shooting down the legs. Okay. So usually the epidural injection is indicated for people who have pain both in the back and the leg, right? That's important. All of these procedures are going to be X-ray guided. You're not sort of hoping for the best and injecting, right? You're going to make this as targeted as possible because the whole point is to get the medication right next to where the problem is. And so, for instance, the medication is usually a steroid. And well, steroids have side effects, and often we prescribe steroids as a conservative measure by mouth. So if you take a medication by mouth, obviously you have to take a high enough dose because your whole body absorbs the medication and only a small amount ends up going to your spine. So in this case, the whole point of the injection is to put a small amount of medication right on top of the problem. So again, going back to our model for all these problems, what we're really doing, the green arrow here is showing you where essentially the needle is going to go. Okay, right next to where that spinal nerve is. So, uh, one of the epidural approaches that I take is called the transforaminal approach. Well, that should make sense to you. The foramen, again, is the window where the nerve comes out. And so transforaminal means, through the window. And so the needle comes in through the side, right next where the nerve is, and by definition, right next to where any disc herniation might be. Okay. So here this isn't one of, well, it'd be a HIPAA violation if I put one of my patients on. So this is let's say a generic picture from a textbook, but this is essentially what I look for when I do my procedures. This is a fluoroscope or X-ray view, and basically the camera gets tilted off to the side so that I have an idea of where that window might be, and the X-ray guides the needle down so that I can see where the needle tip is at all times. That way, as you can see here, the needle tip is in that window. The disc would be right here in this space, and the nerve will be coming out like here. So the idea here is to keep the needle above where the nerve is so you don't touch the nerve. And the whole point of X-ray guidance is to ensure that the medication goes to where it's supposed to go, and also to make sure that the needle tip does not go where it's not supposed to go, right? That should make a lot of sense. And so this is a lateral view, basically a final picture to ensure you're in the right spot. And then, as another feature, we inject radio opaque contrast. Okay, so contrast, the whole point of contrast is for it to show up uh, as this black appearing substance, right? And so what you see here is the needle tip and then the outline of the medication literally going into through the window, which is right here, through the window into the epidural space and on top of the nerve. Okay. Um, so contrast is another way to ensure that you are safely putting the medication where it's supposed to go, and not into, let's say, for a blood vessel, for instance. And also, it's a way to make sure that uh, indeed your injection is accurate. So, for instance, the needle tip might look perfectly located, but if you inject and it turns out most of the medication is coming out here, contrast is coming out here, well, then that's a failed injection, right? So again, that's another safety feature and also accuracy feature, right? So I like using the transforaminal approach for people who have disc herniations or people who have singular nerves that are being pinched. So let's say it's the young patient that very obviously has a disc herniation on one side, and it's very obviously pinching one nerve. I like that approach. I really like because I think it's targeted. Um, there is a trade-off to this approach, and the trade-off is that, well, by design, if we are putting a needle right next to where the problem is, might there be some discomfort as we're putting the medication in, right? Because the nerves are already irritated. And so that's one of the risks and benefits we talk about with the patient in the office. For most people, if it means feeling better afterwards, I think the risk benefit favors doing it, but understand that, by design, there might be some discomfort with that, right? So the next approach is called the interlaminar epidural steroid injection approach. It's also an epidural, okay? This approach is actually the same approach the anesthesiologists do for women who are pregnant, who are about to give birth and labor delivery. Except, in that scenario, it's chaotic, right? You're pushing, everyone's screaming, and usually you're sitting upright. But this approach is the same as that, okay? Now, in a procedure suite with a spine clinic, there's no labor, right? You'll be facing down, you'll be on a table, and it's a much more controlled environment. And of course, we'll be using a camera. And so the idea here is this needle, instead of coming in from the side, goes down straight into the back and it exits and it enters the epidural space back here. Now, here's a good time to start talking about the epidural space. The epidural space is a three-dimensional space that basically lies in between the sac of all of your nerves, and also a small amount of it bathes the actual nerve root as it comes out of the spine. Okay. And the space also is adjacent and behind your disc as well. Okay. So, whereas a transforaminal approach would put the medication right next to the nerve and also right next to the disc, this approach will enter the epidural space, but from the backside. And now, because everything is contiguous, you're hoping that a lot of the medication will wrap around the front, okay? But but obviously coming from the back, there is a chance that the medication does not get to a disc or nerve, for instance. So I actually the question is going to be why do we offer this approach? Well, we offer it because it's a lot quicker. It's a single shot directly down, and generally speaking, it's a little better tolerated than the transforaminal. So for someone that's really like let's say really apprehensive. Well, most people don't like needles, right? We can appreciate that. But let's say you're really, really are afraid of needles, and but you still want to get an injection. I would say let's start with that. That might be a little, better tolerated injection. And if it ends up helping enough, whatever, right? It's a good thing. Um, I typically, okay, so here's a picture of the epidural. So here in this case, you notice the camera doesn't rotate nearly as far. You go basically straight down the spine. And then here's the contrast medication sort of after access has been made going up and down. Better picture would be the lateral view. So here, the contrast is in the epidural space back here. And if you put more in, it'll keep going up the spine. But again, I want you to appreciate in this scenario, even though this is an accurate injection, okay, um, notice how the medication is not going forwards towards the disc or towards the nerve. So that is a drawback to that. All right. Why do I like this injection besides comfort? I like to use it actually for the spinal stenosis patient, right? So remember that earlier slide where there's a big disc here, there's a whole bunch of arthritis here, and there's basically no room for the nerves to come out. Well, don't stick a needle there, but if you stick a needle via interlaminar space right underneath that area in the next level below, right? And you shoot upwards. Well, because it's so narrow there, the medication has no choice but to go sort of throughout the entire area. So I like to actually use it for spinal stenosis patients. It's not rhyme or reason. Okay, it's just sort of like your mileage may vary on your results. If you look at the papers, it's questionable which one is better for the stenosis patient. Whereas it's clear for the pinched nerve and herniated disc patient that the transforaminal approach is better. But I tend to find more favorable results via the interlaminar approach for spinal stenosis. And so that's my reasoning for why I like to do it sometimes. Okay. Um, this picture is a final epidural approach. This is called the caudal approach. In this scenario, the access point for the epidural space is actually at the bottom of your spine, just above your tailbone, basically in between the space where the sun don't shine. Okay. So when would you ever order this injection? Well, some patients will come in and they've already had spinal surgery. Okay. And it's all the way down to L5S1, which is the very bottom of the spine. And when that happens, depending on the scenario, you can still do a transforaminal approach, but sometimes the surgery is so extensive, you don't really, I don't really see a safe access point. Or let's say I try it and I can't get in, right? So the caudal approach is a way to get medication into the epidural space, bypassing all the surgery because it's all underneath. And so what you do is you skip all of that, you put it underneath, and you kind of aim upwards and you shotgun blast a whole bunch of medications upwards for a person that has a pinched nerve in their back, even despite having had surgery, which can happen, right? So that's the caudal approach. And here you can have a view of the needle coming in at again, this is the sacrum. Here, I should use my mouse. This is the sacrum, and down here is your tailbone, and you're basically accessing it at the bottom of your sacrum, and this is the contrast, basically slowly injecting upwards. And you'll see here in this picture, this is more contrast injected, and that will go eventually all the way up to the bottom of the lumbar spine and keep going, right? So the advantage is that, believe it or not, it's actually a pretty simple injection, and the advantage is that it helps you bypass metal hardware from spinal surgery. But of course, the obvious disadvantage is that it is far further away from where a problem might be. And so in order to get there, you sometimes have to inject quite a bit of volume of medication to get there. And volume itself isn't necessarily poorly tolerated per se, but imagine if you're injecting a whole bunch of stuff and you're using steroids, sometimes the volume dilutes the medication. So there are some clear disadvantages of this approach. Hmm. Okay, so that's pinched nerve. That's all spinal nerve root related treatments, right? For the nerves coming out through here getting pinched. Let's talk about the other back pain, right? And that's joint related back pain, right? Arthritis related back pain, which is extremely common. So the term we use for that is called facet joint pain or lumbar spondylosis. But again, all of that just means arthritis in my back. And you would still go through all of the traditional treatments, go through core exercises, maybe take some anti-inflammatory medications. But if that's still not enough, and if your pain lasts long enough, then you might be a candidate for what's called the radiofrequency ablation procedure, or a nerve burn. You go, wow, isn't that aggressive? Kind of, right? There was a point in time, believe it or not, where for the most part we'd be able to inject steroids into the joints. And in select cases, you still can, but without getting too detailed or political, now insurance companies don't pay for that anymore. They don't cover it. And I don't want to get too deep into the woods with that one. I don't necessarily agree with that decision. However, one of the major reasons why it was done is because this particular procedure, the ablation procedure, has much more data supporting its efficacy. So actually, the joint injections are kind of like 50-50. We have solid data about the true efficacy of the ablation procedure, where it's much more than 50%. Okay. So how does that work? Um, well, all of the joints in this diagram's a little messy, but all of the joints in your spine, we've figured out over the last like 4 decades or so that there are these small little nerve fibers that essentially the joint uses to tell your brain, or well, it tells your spinal cord and then tells your brain that there's pain. And it turns out that these nerve fibers, they're only responsible for effectively sensation. That's all they do. And we've been able to map out through cadaver studies over decades where the nerves are located on the spine. And through experiments, again on medical students actually, um, by injecting these different nerves, we've been able to map out what part of the spine they actually correspond to. And we've been doing that for that's been verified for decades. And as a result of that, we've started burning the nerves uh, corresponding to the arthritic joints for pain relief. And we've been doing that for actually a really long time. This technology and principle here is not new. It's decades old, but some of the techniques and some of the I guess technology behind the burning probes have gotten more slick and nuanced over time. All right. So each joint has two small nerve fibers. They're called the medial branches. Don't worry about that. But basically, these are small nerve fibers, and they correlate and supply each joint. Uh, and therefore, when a joint is arthritic and painful, that saved nerve fiber is the highway of information that then tells your body that you have pain. So the idea here relies on the following. Number one, that joint injections uh, aren't as reliable as we think. And my belief, the clinical reason for that is because for a lot of the patients that have bad enough arthritis that causes bad enough back pain to see a doctor, when you actually look at their MRIs, the joint is so arthritic, you don't even see a place to even put a needle to inject steroid. There's like no room, right? Bone on bone. So this ablation procedure is a very reasonable thing, and it's something I do very often and something I do believe in. And it's something I think that is very much evidence-based. So here's how it works. Um, what you do, uh, uh-oh, my computer needs a reboot. No, it doesn't. Postpone like 5 hours. Okay. So what we do is we know where the nerves are and anatomically, and then we have an idea of where the patient's complaining of pain. We get an MRI, and the MRI confirms where we see the most arthritis. But there's no way to prove for sure that that's the place that's causing your pain unless you do these diagnostic injections. In other words, no one's going to burn the nerves in your spine without confirming first that that's the right place to burn, right? That'd be very ridiculous. So again, with X-ray guidance, you drive a very, very small needle down to where these nerves are for the joints that you think are causing the pain, and you put the tiniest amount of numbing medication next to that nerve, and you give the patient a pain diary. You go, hey, do you feel better or not? It's that simple. Do you feel at least 80% pain relief or not? So obviously, if you do that process and it's completely X-ray guided and targeted, and essentially a sniper shot, you go through all of that, and the patient says, I don't feel any better. Well, that's not where you're going to burn, right? That should be common sense. But if we had to go through a lot of research and studies to sort of essentially state that, right? But on the other hand, if you go through the test injection and you feel amazing, you're able to stand up straight, you're able to do your chores, you're able to do your gross, let's say you're able to do your dishes for the duration of that numbing medication, or then that means we picked the right spot. And the way it works is if you prove that, remember these injections are only numbing. They don't actually provide any cure. It's a temporary injection solution. But if it works, what you do is you go through it again. You have to do two injections. So that's based on research, and it's also based on insurance requirements now. The insurance requires that you do two of these injections. But the reason why the insurance requires it is because we have studies that show that people who have had two of the injections that then go on to have the final nerve burning procedure, they have better results than the person who only goes through one series of injections. And why is that? The best guess is that we're ruling out placebo effect for some people, right? So some people are so interested in the procedure that they will themselves to success. Well, you want to avoid that if you're going to be burning something, right? So you do these test injections first. They're called diagnostic facet joint nerve blocks or diagnostic medial branch injections. And the picture here is, again, let me just go back. So we know that the nerves live on the side of the spine here at this junction. And so what I'm trying to show you is that in this injection, the X-ray is guiding the needle down that junction that I showed you previously in the model. And here is the picture confirming that that's exactly where the nerve's supposed to be, right? And again, you don't know for sure, right? But that's statistically, that's where the nerve is based on extensive anatomy studies. And then you inject it, right? Um, Now, the next slide is going to be a picture of the actual ablation procedure for someone that succeeds. And you'll see that the needles are placed a little differently. Um, the uh, the nerves are essentially kind of curved around each joint. They curve around it, right? So you use the X-ray and you guide the needle for the ablation parallel to the nerve because when you burn, the needle goes down here. It's hollow now, so it's a slightly bigger needle. It's not surgery, again, it's just a needle. And then the ablation probe gets inserted here. And the probe only burns at the needle tip. And the needle tip burns in an ovoid fashion. So if the nerve curves around, you essentially want to place the needle tip uh, parallel to it as opposed to directly on top of it with the tip so that you can get a bigger burn. That's what that is, right? And if you notice here from an anatomy standpoint, if you know what you're doing, and if you know the anatomy, and if you do all these procedures, appreciate that this needle here, especially on this view, the needle is nowhere near the spinal nerves. Okay, so the first questions people always ask is, are you going to end up paralyzing me? And the answer is, if you know what you're doing and you know anatomy, that would be almost impossible. It would be, you would be, you would be ignoring a lot of basic tenets of anatomy if you start burning the nerves that go down to the legs. By design, it's very far away from where that problem is. Okay. So you burn to sort of congeal the nerve, and if you go through the process, the idea is that about two-thirds of patients will get 50 to 100% pain relief if they succeeded and passed those two diagnostic injections first, for a duration of between 6 to 16 months. Bell curve, the average being 10 months. And the reason it's only 16 months is because eventually the nerves do grow back, right? So you're looking at potentially doing this procedure once, maybe twice, but maybe once a year. And so, again, it's a trade-off. Ask yourself how miserable your pain is, uh, and are you willing to go through something about once a year to be able to get some quality of life? And that's a personal call, right? But this is a procedure that is considered evidence-based. It's much more than 50% coin toss. It's if you go through the test injections, we're talking more like 70%, which doesn't seem like a lot, but in our world, that's a lot compared to just coin toss. And of course, arthritis is extremely common. So this is something that is, I think, a good one, and it's a safe one. But it's something that you have to be willing to do. So final thoughts. This is going to be my final spiel. Again, by no means a comprehensive review of all the procedures that are offered or available or even done by myself or anyone else at Rothman, but rather I hope a storybook on what the problems are and what the common treatments are. I hope that at least the treatments that I explained today make sense in the context of what's happening to the body, right? But, appreciate how do any of my procedures fix anything? So does the ablation procedure fix the arthritis? Does the epidural injection somehow magically dissolve the herniated disc? Uh, and the answer is no. I don't fix anything. I'm not a fixer. This is pain management, right? We're managing symptoms. And sometimes uh, one injection is all it takes, or sometimes it's, two injections. But then there are some people that maybe need maintenance. Maybe it's 3 injections a year. And there are some people we do injections or procedures for and they don't work, right? And so the bottom line is this. These problems, so to speak, are a reflection of time on the planet. There are some people that experience a lot of gravity in a short period of time. So think about a football player or my example, one of the patients I treated was a very young guy, but he was a fighter pilot. I'm not talking about American Airlines. I'm talking about fighter pilots. So he flew F-22s, which meant he did a lot of dives like this, which means he experienced 9 times the force of gravity into his lumbar spine very quickly all the time. And so he had horrible looking discs for a young person. But whether you're that person or someone that's, 85 years old, the point is it's just gravity and time. And to some degree, these problems are a reflection of time spent on the planet. And so to reverse the thought, I hope that you appreciate that, you know, even though there's no cure, so to speak, and in even surgery, the great fixers may not cure everything. To some degree, some of this is appreciating that you've been able to live long enough to experience this, right? The best example I like to give people is that the average life expectancy back in 1850 which is around the Civil War era, right? The average life expectancy back then was 40, plus or minus 5 years. So people didn't get to live past 50. They just died. They died from infection. They died from famine. They died, we didn't have penicillin back then. We didn't have antibiotics. Surgeons back then didn't realize that they had to wash their hands before operating, right? The whole, germs going into a surgical wound wasn't a concept. We didn't know, right? So things today are a lot better, right? We're able to live a lot longer. It's not the life expectancy today based on 2024 numbers is something like 77 for the average person, but not unusual to be able to live into your 80s, 90s, 100 now, right? That's not unusual. We've gotten a lot better at that. Unfortunately, we have not gotten as good at quality control and life quality. So we have the years, we have not been able to figure out how to maintain. And so some of that is expectation management, and some of that is sort of adjusting your routine. We want you to enjoy, I want you to enjoy your life. I want you to do your hobbies, and I want you to, do things that make you happy. But maybe instead of, I don't know, 2 days or 3 days of golf, maybe one day, right? Or, maybe instead of a 5 mile run, maybe 4 miles, right? There's a little bit of adjustment because you're fighting really two variables that are undefeated. You're fighting father time and you're fighting gravity, right? So again, that I hope that gives you, some insight on the procedures and some of the diagnoses and some of the thought process here. I think I'm running out of time here, so I think at this point, I thank you for your time and attention, my resources and citations, and I think there's a whole bunch of questions that we're going to try to get through.
Thanks, Dr. Zhang. That was amazing, so informative.
Thank you.
Okay, there's some questions coming in. We have about 10-ish or less minutes, so we'll get through as many as we can. Appropriate questions, and if we don't get to yours, we apologize. And again, we did record this and we will be sending it out sometime this week. All right, the first question. Hi, Doc. This person is 78. They're a golfer. They're very active for their age. They had a spinal fusion 2 years ago, L4 and 5, but their pains are increasing at their lower back now, along with knee pain over the last 3 months.
Okay.
They had PT, which helps a little, had several injections prior to surgery.
Mhm.
What are the options now? Or what could they
Well,
do?
without getting too I appreciate that some more specific answers will probably require, I can't answer, let's say, with 100% accuracy without looking at your MRI, without looking at you as a person, so on and so forth. But so I'll try to keep things general. But generally speaking, first is letting your surgeon know, right? We'll assume you've done that already and making sure there's nothing wrong with the surgery. I think that's important. Number two, just because injections maybe didn't work before the surgery does not mean that you don't have an option or avenue for that afterwards. So, so what are post-surgical pain issues? So again, assuming nothing wrong with the surgical hardware, which is a possibility, sometimes people herniate new discs, right? Even at the same level of surgery, that's possible. Number two, if it's been long enough, sometimes you develop scar tissue in the area around where the surgery is. And if it's an area that isn't touching a nerve, it doesn't matter. But if sometimes the scar tissue forms on top of the nerve, and that can cause pain going down the legs, and that's a challenging one. Okay. And lastly, it's the more scary stuff. Like if this is pain that's associated with fevers, chills, and all that, you do have to think about infection as well. So again, the answer really depends on what the actual scenario is. But assuming it's not an infection, assuming that the surgery was technically successful for your prior issue, might there be a new problem developing? Possible. And is there an indication to then retry injections after surgery? Yes, as long as the surgeon's okay with it. And yes, as long as you fully healed after your surgery. Okay. The last thing I'm going to say is that there is a concept called adjacent segment disease. What it means is that if your spine is multi-segmented and it's supposed to move, and then now you suddenly had surgery and they fused you, well, now those areas of your spine don't move anymore. So that means all the areas above your fusion or even below your fusion now have to work double time to give you the same range of motion. If you do that and you multiply these ranges of motion over the course of years, well, then a few years after your surgery, you can develop a new problem at the level above your surgery because you're just working that spine, that part of your spine much more often. It's a concept called adjacent segment disease, and that's also a possibility. So you might have a new problem at where your surgery was. You might have a new problem above or below where your surgery was. or there might be a problem with the surgery itself. That all of that is a possibility. Options would be, PT in the beginning. Options would be trying some injections. Options would be trying some medications. Worst case scenario, and I don't want to get too deep into this because we're going to get lost in the woods here. There's something called a spinal cord stimulator, where that's designed to help people who are no longer candidates for more surgery, or if they've already had tons of surgery and don't want any more themselves. And what it does is it's a way to sort of implant something to then hide the pain signals coming from the back. So that's like a procedure of last resort, and really is meant to hide pain, doesn't really address the problem. I would start with finding out what's going on first and going from there.
Thanks, Dr. Zhang. Some great questions coming in. Can you talk a little bit more about medications that may help?
Sure. So, there's lots of medications. The different classes that people are familiar with are anti-inflammatories, whether it's a steroid, non-steroidal anti-inflammatories, nerve stabilizing agents, and then muscle relaxers. And you'll find a lot of emergency rooms and urgent cares like to prescribe some combination of steroid or muscle relaxers. By and large, I don't have a problem with muscle relaxers, but for the most part, I view muscle pain in this story, this context, as a victim as opposed to a primary source of pain. So, for instance, if you're like 35 and were helping your friends move into your move, and you so-called pull your back. Well, that's usually a muscle strain. That's actually a muscle problem, and that might benefit from a muscle relaxer and some anti-inflammatories. But for this story that we're talking about, usually it's a nerve problem. And remember that the muscles are supplied um, by the nerves. And so you can irritate a nerve from a disc herniation, or you can irritate a nerve because the bones are touching it, or you can even have joint pain. And because there are nerve fibers that the joint uses to tell your brain you have pain, well, some of those nerve fibers have tributaries to the muscles as well. So sometimes the muscle pain is actually indeed a reflection of a deeper problem. And so muscle relaxers in general are not my favorite medication, although I do prescribe them from time to time. I prefer nerve medications. The common ones that we think about are gabapentin, and that serves as a nerve stabilizer. And it works by essentially telling the nerves to talk less, right? So if you have pain, a nerve somewhere is telling your brain, I have pain, and gabapentin slows it down. Okay. You have to balance out side effects like everything else. Gabapentin can make people sleepy. But the trade-off is some people can't sleep because of their pain. And so that's a good one. I do like some combination of anti-inflammatory medications. And that's usually something we use as needed, and usually more for acute pain. But sometimes people they really need something. So most of the time when it's degenerative and arthritic related pain, there's some inflammation, but not really that much, right? So I try to use that sparingly as well. Steroids are something I use for people who have really bad exacerbations of pain. So like that's like a strong anti-inflammatory. So like let's say someone doesn't usually have pain and suddenly they walk funny and there's like a really severe episode of pain shooting down the legs. Sometimes I'll prescribe steroids for that just to sort of nip that problem in the bud to avoid having to do a procedure. And that's basically the gestalt. Now, of course, there's always opioids. I will tell you that Rothman's not really a pain practice per se, but in let's say someone just broke their bone, a compression fracture, that's an indication for some opioids, and that's for acute pain management. However, I will say that besides the obvious that they're potentially addicting and all that bad stigma associated with it, opioids have never been proven to have good benefit for nerve-related pain. In other words, they're not really designed for pinched nerves in the back. They're really more for like ouch, I broke a bone, or ouch, I stubbed my toes kind of pain. It's a different kind of pain. It's called a noxic stimuli or nociceptive pain. And so, I want you be careful with that, right? In the right context, certainly it's, in short doses, it's reasonable for pain management. But I really don't like prescribing that for nerve related issues because there's no evidence proven that it actually works for nerve problems. So that's my spiel on that, on medications.
Thank you. There's a couple questions or mentions of the mild procedure.
Oh, I love that stuff. So,
Yeah.
yeah, sure. No problem. So I don't want to get in trouble here, so I'll speak candidly and then I'll speak politically as well. Okay. So Rothman's not So I previously worked in a different practice that was an independent practice where it was basically a whole bunch of interventionalists and physical medicine and rehab physicians. So I've done quite a lot of mild procedures. It is indicated for people who have spinal stenosis that is essentially moderate grade and no more than that. I have seen people do it in the context of severe, but if it's severe, frankly, you should probably see a surgeon. And that's the bottom line there. So the mild procedure is the principle that, as you have stenosis, right, there's a disc problem, there's a joint problem, and then what I didn't spend too much time talking about is that there's also a ligaments problem. The ligament problem is basically a layer of cartilage, if you will, that surrounds your spinal sac. And what ends up happening is as things degenerate over time, like all things, right? Your body puts down extra calcium, puts down extra whatever, and the ligament essentially reflects wear and tear by getting thicker. Okay, so because it's made out of essentially cartilage, if you grab a thick chunk of your hair, it's really strong, right? So the mild procedure is a procedure where you use a hollow tube and you tunnel in and you scrape away that ligament from the backside, not where the nerves are, but from behind, to essentially thin out the cartilage material, so that instead of pulling a chunk of hair, you're now pulling a small strand of hair. Okay. So the idea is that it allows some flexibility so that the nerves have a little bit more wiggle room to go through the spine, right? So you're kind of reducing remember, the whole thing is a sac filled with fluid. So you're kind of reducing some of the pressure that way. And I've seen the mild procedure work very nicely in that context. But appreciate that what it doesn't address is the joints that are arthritic that are also pushing into that room. It doesn't address the disc bulge either. So it only addresses one component of a three-dimensional orifice. The next thing I'm going to say, and this is going to be more of a hush hush kind of thing, we don't really do that at Rothman. Okay, so I don't want to get into trouble. And the reason is because this is a spine surgery office, right? And whether you, depending on who you talk to, the mild procedure to me is a minimally invasive procedure, but to some others it looks kind of like surgery. And I don't blame that mindset. I think that actually is correct. So from that context, right, there are also physicians outside of Rothman that do this procedure, but you have to be careful. It's only indicated for moderate. When it gets severe, which is frankly, that's what a lot of my patients are, technically speaking, the mild is not the right procedure. You should be seeing a surgeon for that to open up the severe stenosis. And that part I do agree with 100%. The mild procedure is for people who have classic symptoms of stenosis. Back pain with leg pain, worse when they stand, worse when they bend backwards, gets better when they sit down, and with MRI evidence of about moderate grade stenosis at most, not indicated for severe stenosis. Hope that answers your question.
Thanks, Dr. Zhang. Great explanations. I know we're at like 6:03 right now. It's maybe one or two more questions, and then we're gonna have to wrap it up. Let's see. Someone asked, how do you determine what type of injection is used? And with that, uh, I guess between epidural or steroid, and how long do steroid injections last?
Sure. So determining that sort of depends on what the presenting symptoms are and what the MRI looks like, and to some degree epidemiology and patient preference, right? So the transforaminal approach is the bona fide more accurate approach, right? It's right next to the disc, right next to the nerve. So indication for a transforaminal epidural injection is for a single-sided disc herniation with one nerve being pinched, right? In which case it makes sense to put the needle right next to that problem. Okay. Um, uh, however, uh, okay, so the interlaminar approach, which is the injection where the needle goes down the backside or down the middle, um, the advantage to that one is that it's a little faster, and for a lot of people, it seems to be better tolerated, although I would argue they're both pretty decently tolerated. Um, and I like to do that when there's two scenarios. One is if there's spinal stenosis, because again, with spinal stenosis, there's three-dimensionally, uh, it's not just one disc problem. It's disc bulge plus arthritis plus, so there's it's unclear what's exactly causing the pinched nerve. And so that's one area where you can put the medication in from the back and basically it'll shock and blast the entire. So it's less specific and more general. And I think that's a reasonable approach for that. The other reason to try it is if someone's really needle averse, and that injection takes a little less time than the transforaminal. So it's kind of like a, hey, I'll keep your suffering to a minimal. And I hopefully get this done quickly for you so you can get off the table. But again, it depends on the patient. And the caudal injection is for people who either have tailbone pain in addition to pain going down the legs, or they have had a whole bunch of surgery and I'm looking at the MRI and I don't see any room for me to put my needles. Then you do the caudal approach to avoid that and basically hope that the medication goes all the way upwards.
Thanks, Dr. Zhang. Okay, apologize if we did not get to your questions, but we are running out of time. As mentioned, we did record this, so we will be sending it out midweek. It will be available on YouTube as well. If anyone would like to make an appointment with Dr. Zhang or anyone at Rothman, you can always feel free to reach out to me. I'm happy to help facilitate that. You all have my email. So thanks again for your great presentation, Dr. Zhang. Thank you all for joining, and I hope everyone has a great night and a great week.
Thank you for your time, everybody. Thanks for joining me.